Welcome, ladies and gentlemen, to the ESRS webinar on hot topics in obstructive sleep apnea, a European view. Respiratory sleep medicine is a fascinating area in clinical practice and scientific research. While efforts to expand this field have been made worldwide, we must especially commend our American colleagues for setting the stage in the past decennia. The American Academy of Sleep Medicine has done a lot of work in publishing practice manuals and guidelines. In recent years, however, both the European Respiratory Society and the European Sleep Research Society have made major contributions to the field. And now we may have come at a pivotal moment where novel European ideas and insights may fuel the development of new paradigms that in turn may improve clinical practice in sleep medicine. Today, the theme of the webinar is respiratory sleep medicine, obstructive sleep apnea, to be precise. It is a pleasure and a privilege for the European Sleep Research Society to offer you this educational opportunity. We are pleased that 5 opinion leaders in the field have consented to give a lecture. The topics for today cover diagnostics, comorbidities, evidence-based medicine, treatment issues, and finally, organizational aspects of healthcare based on national knowledge-driven systems. But before we begin, there are a few housekeeping points. During and after the presentations, there is a possibility of asking questions, and we encourage the audience to make use of this facility. After each presentation, we will address a couple of questions, and at the end of the webinar, some time will be reserved for a general discussion and for answering some additional questions that are relevant for the topic. May I kindly ask to the people who are participating to turn off their microphones while they're not talking, not communicating. And I also would like to remind that this webinar is being recorded. And it will be made available to the public after it's finished. So without any further ado, I would like to introduce the first speaker, Professor Erna Sif Arnardottir, who is Assistant Professor at the Department of Engineering and Department of Computer Science at the Reykjavik University. She is also Director of Reykjavik University Sleep Institute, and she is the motor behind Sleep Revolution. The title of her talk is The Diagnosis of Obstructive Sleep Apnea, Revolutionized. Anna, the floor is yours.
Thank you very much, Dirk, and thank you to everybody who is here listening today. I'm going to share my screen. Okay, so hopefully you all see my slides now. Excellent. Okay, so today I want to talk about part of the sleep revolution. For those of you who are not familiar with the sleep revolution, this is a 15 million euro Horizon 2020 project, so supported by the European Union. We have 39 partners all around Europe and in Australia. And we at Reykjavik University are leading this project. So the overall aims of the sleep revolution are fourfold. First, to transform the current diagnostic methods for sleep disordered breathing. Secondly, to bring advanced sleep diagnostics from the hospital into the patient's home. And this is the one we will be focusing on today. We need to promote participatory healthcare with technological solutions, and also to develop different personalized treatment options for sleep disordered breathing patients. So at the Sleep and Breathing, we will talk more about the other 3 aims and also hopefully at eSleep in September. But for now, we are focusing on the advanced sleep diagnostics at home. So here we're talking then about a type 2 sleep study. So if you are not very familiar with the 4 different types of sleep studies, as well as the ones that are more consumer ones, I recommend you look at our paper from 2021. It's a review on this topic. but here we are really focusing on the comparison of doing the so-called gold standard or reference standards of a type 1 polysomnography in the laboratory compared to a type 2 one, which is basically all of the same sensors at home without the video. And in this case, then doing this self-applied, instead of having to come into the lab, set up the device and go home, or as in some countries like in France, where professionals will come into the home, set up the equipment. So this is of course quite costly, time consuming for valuable staff. And we have a long waiting lists, especially after COVID. So I know in some of our partner institutions, the waiting list now for a sleep study for obstructive sleep apnea is more than 2 years. So we really do need to make changes to the way we work. And the big question is then, can we bring advanced sleep diagnostics from the hospital into the patient's home? If we are going to do this, we need to compare the quality of the signals of whatever device we are looking into, and the way this is scored by manual scoring, expert sleep technologists compared to polysomnography, or the traditional polysomnography. You also need to look at the self-applied quality of the study. So if the patient is setting it up themselves at home, how is the quality? Is enough of the study is valid? What is the experience of the patient and the research participant in doing this? What can we do to streamline it? And you have to make sure you validate it for the relevant patient group. So for example, if you're going to use this in children, you have to, of course, validate it specifically for children versus doing this in an adult population with sleep disordered breathing, for example. So, and finally, if we are really going to do this and increase our throughput, we also do need to have more validated automatic analysis. And I'm going to come into this point a little bit at the end, how we can increase our throughput in this way. Instead of having 2 to 3 hours of manual review for each PSG, can we really reduce this into maybe 30 minutes, something like, or less? So first of all, what we've been doing is we've been doing double setups. So to make a head-on comparison of the signals and then the manual scoring of a new setup, in this case, is this frontal EEG, which can be self-applied. But in this case, both of the devices are set up by expert sleep technologists and trained staff. So you actually have like this, this is one of our PhD students, which was nice enough to be for this picture. He has 2 devices on then, with the traditional PSG and this new frontal setup. We've already published in 2021, where we did a comparison of the signals for a pediatric cohort. This is over 100 children. And we are now finalizing a paper where we did the same for 174 adults. So these were both adults with sleep complaints, obstructive sleep apnea, insomnia, restless legs, so the most common sleep complaints, as well as some healthy controls. And here are some data from the signal comparison in the adults. So this is a PhD student, Mattias Rosanen, who's the first author of this paper from the University of Eastern Finland. And here you're looking at the power spectral density, comparing the PSG signals in green and blue versus the self-applied signals in orange and purple. And you can see that across the different frequencies here, from 0.3 up to 40 Hertz, the power spectral density is consistently lower for the frontal EEG. So that it is capturing the signals across the frequency range in a similar way, which is very important, but it is lower. So on average, the amplitude, like here for deep, when a person is in deep sleep or sleep stage 3, it's 40% lower amplitude. And this means that when you're scoring sleep stage 3, you have to change the cutoff to score it from 75 to 45 microvolts. And also it's really important if you start changing, for example, the high pass filter to 0.5, which can make the signals look better for this particular setup. Then again, this affects the amplitude. And in this case, this means you will have to change the amplitude cutoff to 40. So you really do need to test and validate the specific new setup that you're using. If we then look at the manual sleep scoring, we are finalizing, we have an expert sleep technologist at Reykjavik University, Erna Sif Arnardottir. She is finalizing this paper. We had 102 children, and she blindly scored both of these setups. And for the frontal EEG comparison to PSG, if we look at just wake, non-REM and REM sleep, the overall accuracy is 93.6%. If we look at all of the different sleep stages, from sleep stage 1 then, 2 and 3 as well, the overall accuracy is about 80%. So this is quite similar to when you look at inter-score variability for everybody scoring the same PSG study. So this is really on par with the accuracy that we are used to in sleep staging. It doesn't mean we don't want to improve it further. That's one of the things we're looking at in the sleep revolution. I'll tell you a little bit about that at the end, but it is quite on par. As to be expected, and we see quite, and basically in every publication looking at the accuracy of sleep stage 1, that is always the worst. Something to consider for the future if sleep stage 1 is really giving us any added value in our scoring, because it is very inconsistent between scorers. So we then say that the signals and the scoring appears to be quite good across the self-applied versus the typical PSG. We are finalizing a paper now for the double setup with in the adults cohort. We will hopefully have some data on that at Sleep and Breathing. But then you also need to look at how it works for patients to take the study home, set it up themselves, and sleep with it. Here we are actually testing this for 3 nights instead of just the typical 1, because we want to look at variability between nights, and also the effects of having this adaptation night we often talk about but never actually use in our clinical practice, to see if night 2, for example, is better than night 1. So in this case, we have a video. It's roughly 8 minutes, and we just give people this back with a QR code for the video. There's a small brochure as well, and then people have all of the stuff they need to set it up themselves. And how does that go? Here we did a study, which we're finalizing with Winfried Randerath, a PhD student of ours, where we had 77 participants, 42 females, 35 males, and they average age 45, but it's a quite broad age distribution, which is important because we want to see if people who are, for example, elderly can still set up this device themselves. And we had people set it up then for a maximum of 231 successful nights if everybody sleeps with it for 3 nights. Out of the 77 participants, 76 actually tried setting it up. 1 person decided just not to set it up, which of course can happen in a research study. This was not for clinical reasons that they were doing this sleep recording, but many of them did have sleep complaints. And of these 231 nights, we had 82% valid nights. And this meant, if we break it down a bit more, 61% of participants had all nights valid, so we could really get the 3 nights. 26% more had 2 valid nights, and 12% had 1 valid night. So we actually only had 1 participant where we couldn't score more than 4 hours of sleep data for the 3 nights they had the device. So we consider this also a success. And we are doing more things to improve based on patient feedback and participant feedback, what we can do to improve it even further, the patient experience. So if we look at the time it took patients to set it up themselves at home, you can see from night 1 to night 3 that the time is decreasing. So like the number of participants who took less than 15 minutes to set up goes up to almost 60% across the 3 nights. We did have some participants where it took more than 30 minutes, but that decreases a lot after night 1. Also, if we look at the subjective sleep quality, we had about half of participants on night 1 that they slept as normally. We actually had 12% who said they slept better than usual. These are very likely the people with some insomnia complaints. But you can see that this starts to normalize. So on night 3, we are getting closer to people's usual sleep quality. Still have 37% who say they sleep worse, but it is getting closer. And this was also confirmed in the objective sleep scoring, that the average objective sleep efficiency went from 82.6% to a little bit more than 89% across the 3 nights. So we are getting closer to people's actual sleep. To finalize, I wanted to discuss a bit the scoring. So one of the issues we have with doing more sleep studies, for example, changing from 1 night to 3 nights, is of course the huge amount of time it takes to manually score all of these studies. And we're looking at different ways to improve automatic analysis in a way where we can trust it better. and for example, that we could only look at areas where people typically disagree and where automatic analysis is not doing great in sleep staging. And to do this, we had 10 scorers from across Europe and in Australia, all expert scorers. They all scored the same 50 polysomnographies and same 50 self-applied studies with our setup. And here you can see an example of a study where the agreement is quite high, as high as it was could get in our comparison. So here you see score from 1 to 10. And you can see the agreement at the top, the blue line. In some cases, like here in the beginning, it's almost full, like everybody is agreeing. And the agreement was quite high here, for example, in the first sleep stage 3 period in green. But in other cases, for example, as for sleep stage 1, the agreement is much lower. So not everybody is agreeing on when the person is falling asleep and then when you switch down to deeper sleep, for example. And we see also that as the sleep becomes more fragmented and the person is sleeping worse, the agreement between scores becomes lower as well, as can be expected because there's more switches between sleep stages. And here, for example, you can see a person which is going a lot from sleep stage 1 to 2 and is having a hard time staying in sleep stage 3. And then the agreement between score is quite low. Actually, interestingly, we had in 48% of all epochs, everybody agreed. But for sleep stage 1, it's less than 1% of the scored sleep stage 1 epochs that people agree. So again, sleep stage 1 is a very tricky one, and we do need to consider if it is relevant to be used for clinical purposes in the future or not. And to do this more automatically, we're actually using this hypnogram of the 10 different scores here labeled from 0 to 9. And you can see areas like here for sleep stage 3 where everybody is agreeing, everybody agrees at sleep stage 3. And then there are areas where people start to disagree, for example, going from sleep stage 1 and 2 to REM. Here actually combine and sleep stage 1 and 2 because, like I say, sleep stage 1 is so hard to score that we can't really rely on it at all. And then we can highlight areas for manual scoring in the future. So we can use the accuracy and of the scores to train automatic analysis. And we can see also the likelihood of the automatic analysis being very sure of itself, basically, that it knows that it's scoring sleep stage 3 or if it's closer to actually guessing. And then you can really review those areas of the recording. So instead of having to review everything, we plan in the future you only have to score parts of the study. And we will be validating this in the prospective studies that are coming up in the sleep revolution. So to finalize, can we bring advanced sleep diagnostics from the hospital into the patient home? Our answer is yes, this is feasible, but to do so, you really do need to validate your particular setup, the quality of the signals and scoring compared to BSG, and we believe we have done so. The self-applied quality of the study, the patient experience, and to improve this as much as you can. And then you have to validate it for the relevant patient group. And for increased throughput, this is still work in progress, more on this at Sleep and Breathing, but we really are working to validate the automatic analysis and we're doing this work together, interdisciplinary between people with a more technical background and then the people who are used to the scoring, people with a clinical expertise in sleep staging and scoring, to really make this robust and work that can be used in the future for both clinic and research purposes. So I want to thank you for listening, and just to highlight, this is from our latest meeting of the Sleep Revolution group, that we are a huge group of key opinion leaders in Europe in sleep, as well as people with different technical backgrounds and coming from other fields. And by working together, we believe this is the way to improve our field for the future. Thank you.
Thank you very much, Erna, for sharing this exciting data with us. This is really groundbreaking work, I would say. Now for the audience, I would like to repeat that if you have questions, please use the questions and answer button, which is in the bar below. And we are not going to respond to hand raising because there's too many people. There's a whole lot of people now attending this webinar. I haven't seen any questions so far on your topic, Erna, but I have a question myself. And now this is a totally new approach, and for sleep recording, you're really geared with recording frontal electrodes, not central electrodes, occipital electrodes, which gives a limited picture of the EEG. I think this may have implications for scoring manuals as well. Do we need a new scoring manual for this?
Yes, so that's an excellent question. And one of the things we are doing in the Sleep Revolution project, and will be one of the final products we make, is a new, we call it the European Scoring Manual, because we believe we need to change the way we score and base it more on research studies, validated outcomes. So is the AHI all we need, or do we maybe need some other indexes to see if someone has sleep disordered breathing? And we believe we do, but we want to base all of this on research. And interestingly, when the ASM updated their manual, they did not change, for example, the amplitude of sleep stage 3, even though we switched from scoring it mostly on the C channel to the frontal channels. So this is something that probably should have been changed when this was moved, but it wasn't. I do see 3 questions here actually in the Q&A. Dirk.
Yes.
Do you want to choose from these, or if we have time?
Yeah, they're popping up here. So maybe the first question, which ASM scoring criteria was used for the study?
Yes. Excellent question. So this was the latest one at the time, which was 2.6. So now 3.0 just came out, which is the newest one, but there's very little changes from 2.6 to this one.
Yeah. And the second question is about artifact, recognizing artifacts and rejecting.
Yes. So there is, of course, a little bit more artifacts when people are allowed to take things at home compared to when you do things in the lab where you can fix things. But we reviewed all of the studies, and like I showed you in the flowchart, we had about 80%, 82% of all studies were considered high enough quality to score for out of these 231 nights. So everybody except one participant had studied at least one night that we could score.
Yeah. So time is limited. We will not be able to address all the questions, but maybe the question on the costs, it's about cost reduction. So the self-applied method, just a ballpark figure where we are in cost reduction when we're using the self-applied sonography.
We will be able to answer this after we do the prospective study with the ASADA group. We will have 1,000 patients in 24 centers across Europe, and we will be measuring the time difference from doing the typical clinical routine to the new one. So I don't have an answer at the moment, but we believe it will be significant. Yeah,
thank you very much, Erna. So time to move on and to move over to a well-known but also much debated aspect of obstructive sleep apnea, which is the association with comorbidities. And it's my pleasure to introduce Professor Maria Bonsignore, who is a full professor of respiratory medicine at University of Palermo, Italy. Marisa, the floor is yours. Thank you.
Thank you, Dirk. Let me share my screen. Just a second. Share. Desktop, no, here. Okay, thank you very much for organizing this interesting hot topic webinar. So my task is to talk about comorbidities, and I started with a major question. What are we talking about? Just a second, I have to switch things okay. So what does comorbid mean? It means existing simultaneously with and usually independently of another medical condition. And this is the Merriam-Webster dictionary. Where are we actually in the real life? Here is a study of the comorbidome of patients with sleep apnea in relation to mortality. This looks quite complicated, but actually what each big circle means is a certain disease, in this case hypertension, and the circle is larger for higher prevalence of the condition. So in red, we have the cardiovascular comorbidity. In light blue, we have the psychiatric comorbidity. In green, the respiratory. In brown, the metabolic. And in orange, the gastrointestinal ones. So the risk, to have a significant risk, you have to be inside this big circle and death. So the outcome is at the center of this big circle. So whatever is significantly increasing the risk of mortality is closer to death compared to things that are less relevant. So here you see that there is a certain distribution. Whatever is half and half is not significant. So there are certain conditions that increase mortality in patients with sleep apnea. More clearly, and let's go to numbers, you see hypertension as a high prevalence and a moderate risk, whereas end-stage renal disease has a very low prevalence, but has a very high risk for mortality. So these authors, based on prevalence and hazard ratio, defined a comorbidity of sleep apnea index and assigned some points. Of course, ESRD was the highest, aortic aneurysm, malignancy, and age are second with a score of 3. And the most common other conditions have a score between 1 and 2. So what happened when they stratified their almost 10,000 sleep apnea patients according to the COSA score? First of all, mortality was 3.2% and was due to cardiovascular disease in 37% of cases, infection 27%, cancer 26%. But the mean number of comorbidities was pretty high because it was 4.4 comorbidities per subject. Interestingly, however, and as expected, I would also add, if you have no comorbidity, the risk of mortality associated with sleep apnea is really very low, and it progressively increases as the comorbidity index increases. But if we go back to the most common conditions occurring simultaneously with obstructive sleep apnea, are they really independent of sleep apnea? And I'm talking about obesity and metabolic syndrome, systemic hypertension, and type 2 diabetes. So I think that we should critically review the comorbidities because there are some that are closer to sleep apnea than others. So we will see whether there is any evidence they are actually independent of sleep apnea, if they improve after CPAP treatment, and whether they increase cardiovascular risk independently of sleep apnea or together with sleep apnea. This is an old slide. It's 20 years old. And I use it sometimes because I think it beautifully illustrates the fact that hypertension, sleep apnea, and obesity not only occur simultaneously very often, but also share some intermediate mechanisms such as endothelial dysfunction or insulin resistance, and very important, increased sympathetic activity. So it is very hard to disentangle the independent effect of sleep apnea, hypertension, and obesity on these mechanisms. And actually, this has been what we've done in the last 20 or 30 years. Maybe we should have a different approach, however, because these things clinically occur in the same patient. And actually, what we care for in clinical practice is how to treat the patient at best we can. If we look at the metabolic syndrome, you all know that the metabolic syndrome means increased visceral fat, and no surprise, because sleep apnea is also associated with increased visceral fat. There is a higher incidence of sleep apnea in patients with a metabolic syndrome. And obviously, there is also a dose-response effect with the metabolic index. So the higher the number of factors inside the metabolic syndrome that are present, the higher is the likelihood of sleep apnea incidence. But there are also some studies that could change a little bit our view. Traditionally, we are used to think of this type of paradigm like intermittent hypoxia causes overactivation of the carotid body, which increases the sympathetic activity, which has an effect on the pathogenesis of hypertension and insulin resistance. However, there are some studies, recent studies, suggesting that obesity and hyperinsulinemia can independently overactivate the carotid body, meaning that the picture I've shown you earlier means that these different diseases actually share and may overactivate the different systems, different pathways, and so they actually coexist instead than together in the same patient in a pathological way, instead than being just a simple association. And the same was more recently shown for an effect of leptin on the carotid body by the group in Baltimore, where they showed that leptin could activate the carotid body, and this would increase the activation of the sympathetic nervous system and mediate hypertension. So for diabetes, for example, again, there is an increased risk of incidence of type 2 diabetes in patients with sleep apnea. And we also know that metabolic syndrome increases the risk of major acute cardiovascular events. And this is true not only in the general population, like in the Finnish cohort study, but also in sleep apnea patients. So those patients with the metabolic syndrome show a higher number of cardiovascular events than the patients with sleep apnea and no metabolic syndrome, just to stress again the importance of the coexistence of these conditions. Another important point is, does OSA contribute to these alterations in cardiometabolic variables? We have some evidence, actually a lot of evidence, that insulin resistance improves, so decreases, if we treat our sleep apnea patients with CPAP. And this is true in non-diabetic sleep apnea patients, but also in diabetic sleep apnea patients. However, you see that for the diabetic part, there is a lot of variability among studies. And this is probably due to the fact that there are some data that, for the sake of time, I'm not showing you, suggesting that to have an effect on metabolic variables, probably 4 hours of CPAP per night is insufficient to cause any change. So cardiometabolic changes would require a longer time. So this study is no surprise. In sleep apnea patients, if we only apply CPAP, the blue lines, we find a small decrease in blood pressure, but no effect on insulin sensitivity or triglyceride levels. However, if we put together CPAP and weight loss, this is much more effective, even more effective than weight loss alone. So it's clear that probably the obesity and the cardiometabolic disturbance are stronger factors than what we can cause, what we can expect as caused by sleep apnea. And recently, the ESRS study published a study on diabetes control, showing that the reduction in glycated hemoglobin only occurred in obstructive sleep apnea patients with concomitant weight loss, in full agreement with these earlier data from Chirinos. There is another major condition often occurring simultaneously with sleep apnea. There is no time to go through all the possible comorbidities except the most important ones, and chronic kidney disease prevalence is increasing because of lengthening of of life. So people survive longer, and so they develop more degenerative disease. So let's ask the same kind of questions we did for the previous set of comorbidities. In the ESRS study, we assessed the relationship of sleep apnea with the prevalence of chronic kidney disease assessed as EGFR by the CKD-EPI equation, and also the other one. And there was no effect of AHI, whereas lowest SpO2, lowest oxygen saturation during sleep, was a significant independent predictor of the presence of chronic kidney disease. Of course, as expected, the classical risk factors are much more powerful in increasing such risk. And there are several papers now showing a bidirectional relationship between sleep apnea and the kidney, as summarized in this slide. So we know that sleep apnea, probably through hypoxia, oxidative stress, and sympathetic activation, and diabetes and hypertension that often are present in the same patient, could potentiate kidney damage. And when this evolves to end-stage renal disease, this is complicated significantly by fluid overload, and this can, of course, by itself cause central sleep apnea, but also promote further obstructive sleep apnea. And this is a similar mechanism operating in chronic heart failure patients. So fluid overload is an important determinant of effect in sleep apnea patients with kidney damage or chronic heart failure. This is a very recent study addressing the issue of mortality and cardiovascular events in patients with both chronic kidney disease and sleep apnea syndrome. Here you see the data, the raw data. You see that without sleep apnea and with sleep apnea, there is a decreased survival. But if we go to the panel on the right, you see that CPAP treatment does decrease such risk. And this is confirmed by the propensity score analysis, matched analysis, that still shows some difference between the group with sleep apnea and without sleep apnea, and the effect of treatment. You see that patients with sleep apnea and without CPAP have an increased risk, whereas CPAP normalizes this risk. This is to say that sleep apnea does certainly something. So it is not a neutral factor and probably worsens whatever is established by other comorbidities. So in summary, I would like to point out the major things that coming out of this talk. First of all, isolated sleep apnea is rare, without comorbidities, is rare. But by itself, sleep apnea is associated with a limited mortality risk. However, there are some comorbidities that are frequently found in sleep apnea patients, and I think it is our duty of doctors to fully investigate them, because they are not only tightly linked to sleep apnea, and possibly this also by sharing some mechanisms, common mechanisms, but we know they worsen prognosis in patients with sleep apnea and also without sleep apnea. And if we have to weigh these factors, probably cardiometabolic comorbidities play a stronger role than sleep apnea, so are more powerful than sleep apnea in the high cardiovascular risk found in sleep apnea patients. I would like to finish with a summary slide that is from an interesting review published in the European Respiratory Review last year, where Gleason and McNicholas did explore critically the level of evidence of the bidirectional relationship. So, for example, renal dysfunction, congestive heart failure cause sleep apnea, but actually there is some evidence, moderate evidence from sleep apnea to renal dysfunction, but very poor for congestive heart failure. And obesity has a strong effect, and a moderate evidence on the other way due to the bad effect of sleep apnea on adipose tissue metabolism. Moderate evidence for stroke bidirectional. Diabetes is certainly increased by sleep apnea, but there is also some evidence for moderate evidence for the reverse. And there is a new kid on the block, that is depression, that is increasingly studied in relation with sleep apnea, but the reverse is not that true. I think that studying bidirectional relationship is useful to understand better the mechanisms, but actually we should go back to trying to calculate an overall comorbidity burden, because the data, at least those for untreated patients, show that the comorbidities, as it is obvious, are an important cause of mortality and also cardiovascular events. So maybe we should also change this paradigm. Thank you very much for your attention. And I'm finished.
Thank you very much, Marissa, for this nice overview and showing all these intricacies of bidirectional relationships. I think that applying treatment, effective treatment, CPAP treatment, will be very important to give an answer on causality questions. And now these new techniques, the propensity score analysis techniques that you mentioned in one of these slides, may be very important or become important, because the classical randomized controlled design trials are now a bit out of fashion, I would say. Could you comment on that?
Well, I think that we should move towards the big numbers and use better the big numbers we have. And definitely the propensity score matching is closer to the real world than the randomized control trial. So the randomized control trial have been important, for example, for blood pressure, but for cardiovascular risk, probably having larger numbers and probably using matched patients with similar characteristics is going to give us better results. Because even if the SAVE and the Ricazza trial did show no improvement in cardiovascular risk in patients with CPAP, treated with CPAP and cardiovascular disease and coronary artery disease, we still, the large majority of us still consider sleep apnea as a potential important cardiovascular risk factor. But I also believe that some of this risk factors depends on the comorbidities. So if it is a lot more logical to address the comorbidities and try to improve the clinical condition of the patient, not only for sleep apnea, but also for other things. Yeah,
that's true. I'm looking at the Q&A box here. I want to pick out one or two more questions. One of the questions is what about the association between sleep apnea and cancer? How strong is this association?
Well, I had to pick up some comorbidities. I couldn't, in such a short time, talk about them all. Now, again, that cancer and sleep apnea is another important association, as I have shown you that about a quarter of patients with sleep apnea die of cancer. But while the evidence in vitro, so the experimental evidence in animal models and in vitro models, suggests an important role of intermittent hypoxia and also sleep fragmentation on development of cancer, gathering the clinical evidence is much harder, and we are not yet there. So I think that there are both sleep apnea and cancer are complex diseases, and probably each type of cancer has its own biological features. So we have to wait until we put together studies for each different cancer type to understand it better.
Yeah. Some more questions pop up here, but I think they may be addressed in the next talk, which is on evidence-based medicine. So we will not invite any further questions on this topic, thank you very much, Marisa. But I think it's time to go on to the next speaker, Professor Walter McNicholas. Walter is a Newman Clinical Research Professor at the University College of Dublin, Ireland. Unfortunately, Walter couldn't be here with us today because he's traveling, and his presentation has been pre-recorded. Any questions related to this communication will be taken, but will be addressed at the end of the session, at the end of the webinar. So please, Lisa, go ahead and show us the presentation by Walter.
Hello.
Oops. Can you see?
See, but not hear.
Welcome.
Okay.
One moment.
There's still no audio coming through.
My presentation today is on evidence-based treatment of obstructive sleep apnea. I have no conflicts of interest, and the objectives of my presentation are to review evidence-based data regarding the efficacy of CPAP therapy for OSA with a special focus on more recent evidence. I will discuss the recent report prepared for the AHRQ in the US on long-term CPAP outcomes in OSA. This report, published in December 2022, involved only randomized controlled trials and non-randomized comparative studies of CPAP that adjusted for potential confounders. The reports included did not evaluate sleepiness or other symptoms, and there were only 52 identified studies, and the authors commented that these used highly inconsistent criteria to define breathing measures. Overall, the authors concluded that RCT evidence did not support CPAP efficacy for any of the outcomes that included cardiovascular, all-cause mortality, driving accident risk, incident diabetes, depression, anxiety, cognitive function, or quality of life. There were many limitations to the report. First, the report was highly selective in that only 52 reports were included compared to the many thousands of reports that are in the literature on this topic. The focus on RCT reports limited patient selection, especially that non-sleepy cohorts were likely included in the main, which resulted in many subjects not having clinical OSA, since we recognize that only 20 to 30% of subjects with an AHI above 15 have clinical OSA syndrome, namely the AHI plus relevant symptoms. Much of the reports included related to secondary prevention of comorbidity, with none looking at primary prevention. They did not consider CPAP efficacy in alleviating daytime sleepiness. And this is very surprising and would be comparable to ignoring dyspnea relief in bronchodilator therapy of asthma or COPD. Further, they ignored extensive evidence from other control studies, such as matched control study designs evaluating driving accident risk. Finally, there were inappropriate study populations included for the conclusions drawn. And a good example here would be using the SAVE trial of largely non-sleepy patients to draw conclusions on driving accident risk. Since most of the studies included in the report used the AHI as the primary variable determining OSA severity, we should consider that other variables have been identified that are contributing factors to comorbidity, And these include sleepiness, hypoxia, and more recently, nocturnal loss of blood pressure dipping. Thus, when we look at a research protocol that would be most suited to study objectives, we should consider optimal measures of sleep disordered breathing, syndrome definition, study design, and recognize that RCT evidence is likely to involve less severe patients, whereas real-world outcome studies allow the inclusion of more severe OSA patients. Patient selection should be focused on symptomatic patients, and we should look specifically at phenotyping of clinical and pathophysiological traits. Finally, in CPAP therapy, we should especially focus on compliance. We recognize now that there may be a bidirectional relationships of comorbidity risk, and this is especially evident in the setting of heart failure or renal dysfunction, both being influenced by fluid retention. And thus, efforts towards removal of excessive fluid would be an alternative management option for treating OSA in such settings. There are many comorbidities that have been associated with OSA and can be considered for outcomes following CPAP therapy. However, in view of time constraints, I'm only going to focus on a selective number of these comorbidities where there is recent evidence to report. First, looking at cardiovascular morbidity and initially hypertension. There is long-standing RCT evidence of CPAP benefit in blood pressure reduction, but these reductions are relatively small, being in the order of 2 to 3 millimeters. And we now recognize in recent years that the loss of nocturnal dipping of blood pressure has an important impact on the outcomes of CPAP therapy in terms of blood pressure reduction. And specifically, it is the group of patients with non-dipping status that show the biggest response to CPAP therapy in terms of blood pressure reduction. And here is a Spanish study showing this very clearly, that blood pressure reduction was only seen in non-dippers compared to dippers. And this was also shown in this more recent study with identical findings comparing dippers and non-dippers. And furthermore, showing that markers of cardiovascular disease such as troponin and BNP levels were significantly reduced in CPAP treated patients as compared to controls. This systems review shows the importance of sleep apnea in children, and specifically shows that comorbidities may be found in children. And this is a meta-analysis of adenotonsillectomy on blood pressure in pediatric OSA, showing that in children with established hypertension, that there's a significant reduction in blood pressure following surgery as compared to blood pressure changes in non-hypertensive children. Primary prevention is an important consideration as compared to secondary prevention. And this is a little teaser in that a study from our own group reported on 20 patients of OSA who were normotensive at baseline treated with CPAP and demonstrating significant reduction in nighttime systolic blood pressure, and particularly a doubling of the proportion of patients who showed evidence of nocturnal blood pressure dipping. Thus, CPAP therapy may be beneficial in primary prevention, but I stress that this is very much a preliminary study. Moving on to atrial fibrillation, it's long been recognized largely from observational studies that CPAP therapy is associated with a reduction in recurrence of atrial fibrillation in patients with PAF. However, a recent randomized controlled trial demonstrated that CPAP was not beneficial in this context in a 3-month follow-up period. Thus, the question of CPAP efficacy for atrial fibrillation must remain uncertain. In the broader context of cardiovascular disease, we're all familiar with the SAVE trial, which demonstrated that CPAP therapy showed no benefit in the secondary prevention of cardiovascular disease over a follow-up of several years. However, this study had several methodological limitations, particularly that patients were largely non-sleepy and CPAP compliance was quite poor. There were similar findings in the RACANSA trial published around the same time as SAVE, but it's notable that outcomes were improved in CPAP compliant patients in the study. Furthermore, in the SAVE trial, a secondary analysis showed that CPAP compliant patients did in fact show improved outcomes, as indicated in panel B of the figure, showing better cardiovascular outcomes compared to the total population in panel A. Primary versus secondary prevention is addressed in the ISAC report, which is published across 2 different publications. The initial report of the ISAC study of 1,700 patients of subjects admitted with acute coronary syndrome found no benefit from CPAP in subsequent cardiovascular outcomes. However, a post-hoc analysis of this study showed that in patients with no previous heart disease and who were admitted for a first episode of acute coronary syndrome, there was, in fact, a significant improvement in subsequent cardiovascular outcomes, as indicated in the blue line compared to the yellow line. Cancer is a subject that is under considerable investigation, and there have been a number of reports suggesting that OSA is a risk factor for the development of cancer. However, this recent report from the ERJ showed that in a 5-year follow-up study of CPAP therapy, there was no difference between adherent and non-adherent patients in terms of subsequent development of cancer. Now moving on to neuropsychological evidence. We're all familiar with many reports showing CPAP efficacy in alleviating daytime sleepiness. And this applies also to patients with mild OSA. Quality of life has also been evaluated in this context. And this study published recently in Lancet Respiratory Medicine from the UK of patients with mild OSA showed significant benefits in a variety of quality of life measures, particularly vitality in patients randomized to CPAP therapy as compared to control subjects. Furthermore, there is RCT evidence of benefit to depression, and this is a secondary analysis of the RACANSA trial showing that in patients with established depression, there was a significant improvement in depression scores with CPAP therapy compared to controls. And this is consistent with earlier reports showing benefits in depression, as indicated in this systematic review published some years ago. In summary, on this aspect, the American Academy of Sleep Medicine performed a systematic review and concluded that PAP therapy compared to no therapy resulted in a significant reduction in disease severity, sleepiness, blood pressure, and motor vehicle accidents, in addition to improvements in sleep-related quality of life among adults with OSA. Now moving on to additional therapies, First, I'll look at mandibular advancement device therapy, and existing evidence supports this device as a suitable first choice, especially in patients with OSA. However, in patients with severe OSA, a recent RCT meta-analysis showed that mandibular device therapy was clearly inferior to CPAP in terms of AHI, ODI, and daytime sleepiness. And overall, the outcome very clearly favored CPAP over mandibular advancement device in this context. Weight loss is another relevant intervention in the management of OSA among obese patients. And this report recently in the Blue Journal looked at lifestyle management compared to CPAP and demonstrated that measures of inflammation, as indicated by high sensitivity CRP, and insulin sensitivity improved on lifestyle measures much more so than with CPAP therapy. And this is particularly relevant in the context of recent reports indicating that pharmacotherapy of obesity is quite effective in weight reduction in this context. Hypoglossal nerve stimulation in OSA has been around for a number of years, dating back to the original report in the New England Journal in 2014. And this report recently showed the long-term efficacy in that improvements with hypoglossal nerve stimulation were retained over a follow-up period of 3 years. However, this form of therapy remains recommended only as a reserve therapy for patients who are not compliant with CPAP. Pharmacological therapy is another area of very active investigation, and there is evidence that pharmacological therapy can benefit upper airway collapsibility, arousal, respiratory control, and sleepiness. Looking at upper airway collapsibility, there are reports indicating that various combinations of therapy can improve collapsibility and reduce OSA severity. This study from the Blue Journal a few years ago showed the combination therapy indicated here was associated with considerable reduction in AHI, which was associated with improvements in genioglossus muscle activity. The further addition of the hypnotic zolpidem directed at the arousal threshold was associated with further improvements in sleep efficiency, the arousal threshold, daytime performance as determined by driving simulator performance, and interestingly was not associated with any change in the AHI. Finally, treatment directed at the loop gain in the form of carbonic anhydrase inhibition has been associated with improvements, and this recent report in the Blue Journal indicated that sulpiam, a carbonic anhydrase inhibitor, was associated with significant reduction in AHI at 2 different dosage levels. Measures directed at daytime sleepiness have also been shown of benefit, and this wake-promoting agent solriamfetol in different dosages was associated with significant improvements in both mean sleep latency testing and subjective sleepiness by the Epworth score. The other wake-promoting agent, pitolisant, has also been demonstrated to be associated with improvements in daytime sleepiness, as indicated. The ESRS published guidelines recently on non-CPAP therapies for OSA, which showed conditional recommendations for bariatric surgery, for CPAP, as recommended over mandibular advancement device therapy for most patients and for other forms of reserve therapy as indicated here. Thus, in summary, we can conclude that the evidence favoring CPAP therapy in OSA is more pronounced for neuropsychological disorders, as indicated in the right-hand panel, and that the evidence of benefit in cardiometabolic disorders is specifically focused on benefits in hypertension, with limited evidence for benefits in other areas of cardiometabolic disorders. Finally, in conclusion, we can conclude that the management of OSA should take into account phenotyping of clinical traits and pathophysiological traits, and use a variety of related measures to indicate the most appropriate management options for OSA, leading to a personalized management approach as opposed to the approach of using CPAP regardless of the individual presentation. Thank you.
Yes, wonderful talk. As Walter is not present, we will not address questions here, but as you have noticed in the meantime, the speakers, the authors of the content are already addressing questions by written answers, so that is helpful. And there is a notice about the black strip masking the title of some presentations. It's a technical issue. Apologies for that. I think we cannot fix it for the moment. And another question about these presentations. Yes, they will be made available for review after the broadcasting of this webinar. They will be put on the website of the European Sleep Research Society for further review. So now we come to another very important question: to treat or not to treat. And Professor Randerath will give you the Baveno perspective. Baveno was a meeting in 2016 among European experts where a lot of work has been done and some new ideas have come out. Now, Professor Winfried Randerath is located in Germany, in Solingen, and Winfried, the floor is yours.
Thank you so much, Dirk. Lisa, could you please allow me to show my presentation? I cannot give my screen to show because it's still on you.
I have stopped sharing. You can, do you mind trying again?
Now it works, it should work.
Okay.
So I hope you can see my screen now. So thank you very much, Dirk, for the kind introduction. Marisa and Walter nicely showed that it's very important to treat obstructive sleep apnea. We have enough data showing that people benefit from positive airway pressure treatment or alternatives. And therefore the question remains, who should be treated? So if we treat everybody, I think we are all clear that we don't have success in all patients in different outcome parameters. So how can we select the optimal patient to treat and not to treat wrong patients? So how do we proceed at the moment? Mostly patients present to a sleep lab with non-restoring sleep, with snoring, with witness apneas. Then we perform a sleep study, a polygraphy or polysomnography. We focus on the AHI, and then we switch over to positive airway pressure treatment. However, we know that the AHI is not very closely related to clinical symptoms, as nicely shown here from Erna Arnardottir in her study from the Iceland population. Only in patients with severe sleep apnea, we have an association with the AHI. And the same is right for comorbidities, for mortality. So there is not a very close correlation between the AHI and these outcome measures. So therefore, Dirk nicely put together this aspect by saying we have to discuss what is the AHI, what is the reason, what is the evidence showing that the AHI is relevant, and we have to state that the AHI has minor relevance in terms of describing the disease and in terms of finding an indication to treatment. And this is because we have so many aspects which define obstructive sleep apnea, which contribute to the clinical syndrome of breathing disturbances during sleep with upper airway obstruction. We have pathophysiological mechanisms. We have susceptibility of patients to breathing disturbances or hypoxia. We have clinical symptoms. We have different biomarkers which have to be defined more clearly in addition or in replacement of the AHI. We have to ask, what about morbidity and mortality? What is relevant for the patient? And what are patient-reported outcome parameters which might guide our treatment indication? So many different aspects, from pathophysiology to clinical symptoms to outcome, which all may have influence on treatment decisions. And therefore, we have to try to find new approaches to our patients. We have to find new group of patients, and that's what we are defining by the term phenotypes. So what are the sleep apnea phenotypes, and which of these phenotypes should be treated? At the moment, there are many studies, many scientific activities asking how to define, how to find phenotypes, and many focus on cluster analyses. One of the most recent cluster analysis is here from the ESRS database published in the last year. More than 5,000 patients were included all over Europe. And what you can see is that the cluster analysis showed defined 7 different groups, 7 different clusters of sleep apnea patients, from obese male patients with cardiovascular or metabolic comorbidities to almost healthy but symptomatic females, young, healthy, symptomatic males. So very different phenotypes, and they were defined only by mathematical methods, by cluster analysis. However, if you start treatment based on the clinical definition, if you compare these phenotypes with outcome of PAP therapy, you can see that there are some groups with very good benefit from CPAP treatment, while other groups only mildly respond to treatment or almost no response, show no response to treatment. For example, young, healthy, symptomatic males or elderly, multimorbid obese patients might have differences in outcome, for example, in terms of the adverse sleepiness scale. So these cluster analyses, these phenotyping might guide us. There are other cluster analyses also describing phenotypes. And here's a study from Mazzotti and colleagues from 2019, published in the Blue Journal. And they also defined groups with symptoms, with sleepiness, with mild symptoms, with insomnia, disturbed sleep. And what they found, what they tried to do was to correlate outcome, cardiovascular outcome, in these different groups. And they showed nice and important differences between these clusters, between these phenotypes, in terms of hard outcome parameters. So the phenotyping, the defining of these phenotypes is clinically relevant in terms of treatment efficacy and in terms of outcome. If we put together the bottom lines of the different cluster analyses from recent years, we can state that most cluster analyses define phenotypes based on clinical symptoms, sleepiness and non-restoring sleep, gender, and comorbidities. And the different cluster analyses had additional parameters, but these were the three main parameters indicating and defining the phenotypes. Based on these considerations, we sat together, as Dirk mentioned some years ago, in Baveno, Italy, and we discussed the relevance of the AHI as our primary biomarker, as our guide to treatment. And we discussed that based on the current knowledge, we should replace the AHI by something else. But what would be a better option? And we discussed that we cannot easily find one single biomarker explaining the whole spectrum of phenotypes, the whole spectrum of clinical symptoms, the treatment response, and cannot allow us to select patients. We have to put together several aspects. One of the aspects is the number of breathing disturbances, which defines the disease. A second aspect is the acute systemic effect, for example, sleepiness, oxygen desaturation, sleep fragmentation. And also we have a third component, the chronic long-term outcome parameters, chronic end organ impact. And then we went another step and we tried to make it a little bit easier. And we said we only use the AHI as a prerequisite. We need the AHI to define the disease, to define obstructive sleep apnea. But for the treatment decision, it's not very relevant because of the very low correlation with symptoms and with outcome. And therefore we decided to put on the x-axis the symptoms, mild symptoms or severe symptoms, and on the y-axis the comorbidities, unstable or uncontrolled comorbidities, or stable disease or no comorbidities. And therefore we have a group A with mild symptoms and minor end organ impact. And it's clear for this group of patients, there's no treatment indication, independent on the number of breathing disturbances. Then we have an intermediate group with severe symptoms, but no end organ impact, or mild symptoms and major end organ impact. And the decision to treatment is due to the discretion of the physician together with the patient. Should we treat in these cases or not? It's an individual decision. And then we have patients with severe symptoms and major end organ impact. And it's clear that we have a clear treatment indication for this group of patients. Is there any evidence that this approach might be reasonable? Again, we used the ESRS database and included more than 1,000 patients and asked on the outcome parameters of the blood pressure and the Epworth Sleepiness Scale. And what you can see here is that there is a clear difference in the groups in terms of systolic and diastolic blood pressure in the beginning. Group A and B were those groups without comorbidities. C and D were the groups with comorbidities. So this shows that the parameters really can be translated to clinical practice. Then if we decide to treat the different groups, then you can see that we have a change of systolic blood pressure and diastolic blood pressure in groups C and D. And these are the groups with comorbidities. So that means if we treat the right patients, those with comorbidities, then we will have an effect on systolic and diastolic blood pressure. And the same is true for the sleepiness. Group B and D were the groups with sleepiness, with symptoms, while A and C were asymptomatic. And if you treat the right patients, those who are sleepy, then you will also have treatment effect. So if we group our patients, not in terms of mild, moderate, or severe AHI, but in terms of symptoms and comorbidities, we can nicely show a positive treatment response. However, the question remains if there is really no need of the number of breathing disturbances. And if we go to the literature, so some older data here from Punjabi and Marine, they show there is actually an influence of the number of breathing disturbances. So if you have a high number of breathing disturbances, you have a worse cardiovascular outcome. This is true, but it's only true for those patients with a high number of breathing disturbances, above 20, 25, or 30, differentiating to the study. So it makes sense to make a next step based on the Baveno classification, to include other parameters, especially the number of breathing disturbances. And this is work in progress, and I would like to share it with you and discuss it with you. Again, we are on the base of the Baveno classification. We have the comorbidities from Baveno, non-controlled or non-comorbidities or well-controlled comorbidities, or insufficiently controlled comorbidities on the other hand. We have the symptoms from Baveno, no symptoms or relevant symptoms. And then we can include two other aspects, age, because we know that breathing disturbances are more relevant in terms of outcome in the younger population as compared to the older population, and the high-risk AHI. And if you put these aspects together, we can say those with a high AHI or with insufficiently controlled comorbidities have a high risk and therefore should be treated. They are on the red side of the traffic light. Those patients with low AHI, with no symptoms and no comorbidities are in the green side of the traffic light. No treatment needed. And again, we have an intermediate group of patients with symptoms, symptoms without comorbidities, or no symptoms and comorbidities. And this is again on the discretion of physician and patient if this patient should be treated or not. But the question remains if the HI is really our best biomarker. And as we discussed before, we have serious concerns on the relevance of the HI because there is almost no correlation between symptoms and only mild correlation with outcome. Is there a better parameter? And there's huge discussion, scientific discussion on the optimal biomarker, and there's growing evidence on the relevance of hypoxia and a new parameter called hypoxic burden. This is data from cancer, the cancer risk, and you see many studies focusing on the association between obstructive sleep apnea on the one hand and the risk of cancer on the other hand. And what you can see here is that there is a clear association between hypoxia and cancer risk, but not between HI and cancer risk. So nocturnal hypoxia is independently associated with all cancer risk and mortality, but HI is not. So how can we define, how can you calculate a hypoxic burden? And in the figure on the upper right hand side, you see two examples. You see a patient with a lower number of breathing disturbances, but deep desaturations. And below you see a patient with many breathing disturbances, but lower desaturation, so lower amplitude. How can you integrate that? How can we integrate the number of breathing disturbances on the one hand and the extent of oxygen desaturation? And there are several ideas to combine these aspects to measure the area under the curve or to measure the 90%, the time with oxygen desaturation below 90% and other aspects. And to give you one example based on this area under the curve, and they showed that those with the most severe hypoxic burden had the least outcome, the worst outcome in terms of cardiovascular comorbidities. So if we do the next step, we can again take the comorbidities from Baveno, the symptoms from Baveno, we can include age, but we can also include, or we can replace the HI by hypoxic burden, and maybe we can get information, future results, showing that this is a better parameter as compared to the HI. So in conclusion, how should we treat? Who should be treated? The decision to treat is based on the respiratory disturbances. They define the disease. They allow us to diagnose obstructive sleep apnea. If we should treat a patient depends on symptoms and comorbidities, and this makes the symptomatic indication or the prognostic indication. And in the final step, we select the treatment based on the pathophysiology, the underlying traits which can be treated, and this leads to the treatment selection. Thank you very much for your attention.
Thank you very much, Winfried, for this excellent presentation. So clearly work in progress on the classification of the severity of the disorder. We're leaving the HI, we're considering the HI as a risk. So if your HI is increased, you have a risk for a clinically relevant disease, but you have to throw in other markers to be sure about that. And it will be worthwhile to see how this fine-tuning, including H and including hypoxemia parameters, will turn out. There's a couple of questions. There will be an opportunity to answer them in writing, but I would like to mention the last one by Professor Schizza, who asks, what are other markers for risk other than hypoxemic burden? For instance, the vascular bed at risk, and other things like gender. You have mentioned age, the age aspect, lower than or higher than 65, but what about gender?
Yeah, gender is an important aspect, and we know that there are huge differences in terms of obstructive sleep apnea between the genders, not only in the over the lifespan. We know about the change in symptoms and the change in number of breathing disturbances in female patients after menopause. We know that we have to focus on other aspects, and I think it's important to include the differences in symptoms into our treatment selection and treatment indication. If you only focus on adverse sleepiness scale, for example, we won't find sufficient treatment indication for female patients. So I think gender is an important aspect. It is included in, it can be included in these schemes, because we would not only include sleepiness, but also insomnia, which is a more important, might be a more important symptoms for female persons, for example.
Yeah. Thank you for this answer. I propose that we move on because we have limited time, and we will address some of the questions in writing as well. And now we come to the final speaker. I would say last but not least, it's my pleasure to introduce Professor Grote. He is a director of the Sleep Disorder Center at the Sahlgrenska University Hospital in Gothenburg, Sweden, and also adjunct professor at the Institute of Medicine at the Sahlgrenska Academy, Gothenburg, Sweden. So, Ludger, please, the floor is yours.
Thank you, Dirk, very much for the introduction. And I'm now presenting a work which we started for more than 10 years here in Sweden, in order to really get a management and knowledge-driven management system of OSA, and probably some kind of a wrap-up Many aspects about the management of sleep apnea patients have been mentioned in our webinar already, and I try to translate it into our approach in Sweden to standardize care, but at the same time to individualize care. And we started this for many years ago, and in the last couple of years, this is really supported by a national initiative. And of course, it has a very national aspect, but I try to highlight those components which hopefully is interesting for the general audience. First, a very short description of the healthcare system. We are more than 10 million citizens, and the healthcare system is financed by public funding, which means taxes. We have a shared responsibility between the national government, and on the national level, the legislation is set, as well as the monitoring and specifically the education of the healthcare experts. On the regional level, we have 21 healthcare regions. There, the actual organization and importantly, the resource allocation is managed. So this is decentralized. By that, we see that there are substantial regional differences in healthcare practice. For instance, some new drug treatments or cancer treatments or advanced treatments are available in certain regions, whereas not in others. Or the outcomes in cancer disease or after myocardial infarction is different between the regions, and this is not explained by the health data. So this prompted, of course, an initiative on the national level that we need a knowledge-driven management, which probably overcomes regional difference in part, and it's really knowledge-driven. And here are the main principles and ideas behind this concept. It's the use of the best available knowledge, which have to be followed up and analyzed, which we have certain very good possibilities to do in Sweden. We want to put new knowledge into practice very quickly. We want to identify areas for improvement, and it's very important to have a patient-centered view on healthcare. For that, there's 26 national program groups were built up, and interestingly, it was first in cancer and cardiovascular disease, but also in pulmonary disease, and the working group on obstructive sleep apnea was built in 2020. So what are the components? The first components, of course, to have guidelines for diagnosis and treatment, which many of you probably already have on the national level. In addition, we now have a care program for obstructive sleep apnea, which hopefully will be decided on the next week. And then we have a national quality registry. It's called Swedish Sleep Apnea Registry, SESA, which we started in 2010, which has continuously grown and is now fully operational. And the guidelines, they of course talk about evidence, knowledge, and can be seen as a practical handbook. The care program itself describes more the process, the patient flow, and has a very strong patient perspective, but it's of course based on the guidelines. And then the National Quality Registry, here we can analyze the status and the change over time in the care offered on the different regions. And of course, it will give us indicators if the new care program, if there's adherence in the actual care. So this is a system which works together and is highly interdependent with the three components. And importantly, the main goal is to create additive value for the patient. Of course, it could be nice for us as the healthcare providers to have this system, but we have to have in focus that it should create additive value for the patient. I want now to present the three components. The first of all, the guidelines. We start with a referral to, with respect to sleep apnea. We have classical medical activity, the phenotyping, symptoms, status, the comorbidities, and the diagnostic sleep test, which in Sweden is almost 99% home sleep apnea test, a polygraphic recording. And actually, I will tell you later, we decided on national criteria for hypopnea and hypopnea definitions, because there are so many definitions out. So we defined that how we want to analyze this in Sweden. And then we have the expert evaluation. Is this clinical relevant OSA, yes or no? Exactly what Winfried told us before from the Baveno classification. And if the decision is yes, there is a clinical relevant obstructive sleep apnea, then we need the decision on what kind of first choice of treatment is recommended. And we want to come also away from the apnea-hypopnea medicine, where you just go after this classification. And it's a little bit repetitive because we, in our expert group, were also very much influenced by the Baveno classification. And we published this in 2021 in our guidelines. We have the same or almost the same dimensions, but we still have the AHI classification because we think in the clinical practice that's an established parameter. Then the symptom dimension, of course, yes and no symptoms. And this is, of course, not the Epworth scale, 10 above and below. It's the full spectrum of daytime and nighttime symptoms of obstructive sleep apnea, and especially the complaints or something a patient is suffering from. Then the cardiometabolic spectrum, controlled or uncontrolled, and the age perspective. And we state clearly, we do not know it's the threshold around 65 or 70. Depending on that, of course, if you have an asymptomatic patient with a low frequency of respiratory events, there's a very weak treatment indication. So these colors indicate treatment indications from very weak to very strong. So with increasing number of events, this turns a little bit yellow. And if you have a high number of events and when you are below 65 and you have insufficiently controlled comorbidity, then of course the indication for treatment increases in our model, probably not as strong as Winfried told you before. We are a little bit more restrictive. However, we also think it's important to focus then in the follow-up that, for instance, the blood pressure control is one of the major follow-up parameters. If there are symptoms, of course, then the treatment indication gets stronger and stronger. Another important aspect, we recommend positive airway pressure, mandatory advancement treatment, upper airway surgery for certain phenotype of patients, weight reduction and positional therapy. And importantly, each patient deserves to get an information about the alternatives. The caregiver, says the doctor or a specialized nurse, can have an idea what's to be recommended, but the decision has to be made together with the patient. Another important aspect is we know that first-line treatment probably don't work very well. For instance, we know that CPAP treatment has in certain patients a low adherence, and it's very important that those patients come fast to another alternative treatment, and that this is discussed with the patient. So a good sleep apnea center provides fast second-line treatment and a good follow-up. Coming from the guidelines to the care program. And here we started from the challenges of the patient. So we had patient interviews throughout the country and try to find find out what are the challenges today. And according to patients, one of the main challenges is the lack of accessibility to diagnosis or treatment, a lack of coordination between caregivers, for instance, between the diagnostic sleep center and the dentist if patients should receive or advancement device, lack of shared decision-making between patient and doctor. So some patients receive only a letter informing them about sleep apnea diagnosis and CPAP treatment without discussion, lack of treatment follow-up, lack of competence, lack of comorbidity treatment. So this care program has typical flow charts for diagnosis, for the treatment and follow-up, and then for each of those boxes, there's a detailed practical description. We have a national consensus by a Delphi round, and we received altogether 39 reviews from different organizations, specialized groups, and regions. In addition, when this care program is approved, there is a mandatory regional gap analysis. So each region is mandated or has a mandatory gap analysis from current practice to the the suggested care flow and an implementation plan. So this is a quite strong instrument to improve the care of sleep apnea patients in Sweden. The third component is the Swedish Sleep Apnea Registry. By today, we have 54 reporting centers. And as you can see on the right, it's the map of Sweden, and the black are medium-sized to large towns in Sweden, and the red dots indicate the centers actually registering patients and dentists. It's sleep centers and dentists reporting patients to the registry. So we have a diagnostic coverage around 60%, probably sometimes higher. CPAP is well covered with 85%. However, oral appliances, we have so many dentists prescribing or providing oral appliances, though our coverage is below 20%. Still, we have a recruitment by approximately 40,000 annual visits, and we have more than 120,000 patients in the registry. Here are some results. As you can see here, the accessibility, for instance, the waiting time from date of referral to date of diagnosis of obstructive sleep apnea. On the x-axis, you have the number of days between 0 and 400. And on the y-axis, you have different centers. And you see the bars. There are some centers who have a waiting time or waiting time of below 30 days. And then others, they have more than almost 300 days. And you see this for the year 2020 and 2021, indicating that waiting lists were at mean higher in 2021, probably due to the pandemic. Another interesting aspect is, for instance, how we score apneas, hypopneas, and we use a very simple parameter. We have the difference between the AHI and the ODI, and depending on how you define the AHI or the hypopnea definition with 4 or 3% desaturation, respectively, the ODI is a 3% ODI or 4% ODI. You can have different aspects. We have this defined how to do it in 2018, and this definition is actually very conform with the definition from the ESRS published in 2023. But what you can see here, that there's a huge difference how the centers actually score the polygraphic recordings, and it's despite that we have a guideline, so there's really room for improvement. Another aspect is informed decision making. Does the patient really need a caregiver? Again, here we have on the x-axis 0 to 100%, and on the y-axis you have the different regions in Sweden. And blue indicates these are the proportion of patients who never met the doctor or the specialized nurse for this for the informed decision making, whereas yellow indicates that this meeting took place. So see, the majority of patients really meet the doctor or the nurse, whereas approximately 20% of patients never do that. Another aspect is, what kind of mask do you get at the start of your CPAP treatment? In the guidelines, we recommend to start with a nasal mask, which is the blue ones. The yellow ones indicate that the patient starts with a full face mask, and brown indicates they get both masks for home treatment. So what we can say from these data is there's a substantial variation in accessibility and clinical practice in the Swedish regions. So to finalize the knowledge-driven management in sleep apnea, what are the achievements and the to-dos? We have now the guidelines describing evidence. We have a care program almost accepted for standardized, at the same time standardized, but also patient-centered, individualized care model. And then we have a follow-up model with our quality registry. We need an implementation at the regional level. It's so important that this is not only a concept, that it really improves the care. We have to organize education and focus groups in each region. And of course, we need regular follow-up. And as you can imagine, this is a fantastic tool for research to be available to the scientific, to make it available to the scientific community. We are of course not alone, it's a team. And we started on the left-hand side when we had the diagnostic guidelines. We started from the quality registry alone, and we're almost only doctors and dentists. Then when this was implemented from the national driven knowledge driven system, we actually enhanced our competence by integrating patients. We had more nurses, we had primary care representatives. So all together, this is a fantastic teamwork. And we hope that this is for the patient's best in the future. Thank you very much for your interest.
Thank you very much, Ludger. This is really, excuse me, very important data showing the heterogeneity in, I would say, almost everything, starting from diagnostic availability, HI scoring, but also access to the practitioner. So you have a very broad data range here. So you show the circle or a closed loop where you start with guidelines, then the implementation, then the registry. Now, I think there is a great job to do here to harmonize sleep apnea care in the country. Do you already have a policy or some ideas how to do that?
I think this care program, it's really on the edge to get published. So it's all, and I think this is a stronger tool, because then on the regional level, we have to see what can be implemented. If you do not have the experts, then you can make the most beautiful schemes and ideas, but then it has to be implemented. And there's also, you know, the resources have to be divided between so many diseases. We are happy that we could get sleep apnea into the system to make it visible and to discuss it. And I think it's so important that we think, we our experts think this is the best. But then we have now a tool to see, is it really the best? What do we really need to do to make it best? And in the current setting, the quality registry, it's not mandatory. It's really, people spend their time to report. Some centers now have an automatic reporting from the medical record into the registry. That's the future, of course, because otherwise it's too expensive. So we have a very much of enthusiasm in many centers, and we have to learn all the way. So we do not say this is right and this is wrong. We have to see and what is manageable. But we have the tools, and we have, of course, the evidence. The evidence, it's continuously changing. Like we heard today, there's so much emergent evidence and thoughts. But we want also to see how to apply it in real life, and to finally analyze: are we thinking right, or do we have to adapt? And to have the patient perspective, really what's best for the patient and not for us as caregivers.
Indeed, indeed. One of the questions here is about the number of centers per capita. Do you think that Sweden is sufficient? Of course, there are interregional differences, but do you think that Sweden is sufficiently covered by sleep facilities? And another question is, along with that, is the opportunity of doing video consultations.
Yes, the first one, I would say, the number of CPAP prescription, for instance, is very comparable. We have actually counted the incident number of CPAP prescription in Sweden is around 160 per 100,000 per year. The number of sleep tests is varying between 150 and more than 300 per 100,000 inhabitants per year. So these numbers we can calculate quite nicely, and I think we are pretty in line with other countries. I'm not aware if other countries have the opportunity to really count them in the same way. And so what's enough and what's not enough, we have to see it. We have so many waiting time lists, so long waiting lists. So therefore we can say where it's not enough.
Sure.
That's the resource. And the other question was
video consultations.
Yes, absolutely, no problem. We see that and we analyze actually if you meet your patient in real life or in the video consultation. And interestingly, during the pandemic, it was more video, and now most centers have got back to the face-to-face meetings actually.
Yeah. So thank you, Ludger. I think there is time for a couple of minutes for a panel discussion. And there's some questions still open. One of the questions is for Erna. What if the 3 consecutive studies you do show completely different results? How do you handle that? Did it ever happen?
This is an excellent question. So in the studies we've done so far, we do see patients with high variability between nights. And of course, these patients already existed. We just only had data for one night for them beforehand. And now that we can actually see the variability, we can address it more with actual data. So for now, I would say you would need to look at the 3 nights and look at the patient profile quite carefully. We can't say you should do mean or you should do something else at the moment, but this is one of the questions that the prospective, large prospective study we are going to be doing will help us with answers. Yeah. But I would say more is more in this regard. More data gives you a better perspective, and you can at least then do like a test period of treatment to see if symptoms and comorbidities are reduced.
Yeah. Of course, this self-applied sonography and polygraphy is an enormous opportunity to increase the scale, so to increase the capacity of sleep diagnostic facilities. And I can open up this question to all the members of the panel. How will that influence our situation in the future? So we saw from the Swedish data that access is still limited. Will this be a true revolution in healthcare? Will we close our beds in the hospital?
I think that closing the beds in the hospital is a good thing, but provided that this is associated with an increased work at home. I'm not sure that saving time is a major aspect of the sleep revolution. Actually, it could also be that increasing the number of patients that you see in a week, for example, actually the amount of work, the workload increases, it does not decrease. So I think that this will be okay if we try to organize our sleep labs in a better way with more personnel, and also especially with telemedicine, who is going to look at the data. So I think that it is a sleep revolution, but it will require several aspects to be fixed in order to make it valuable in terms of daily work. Certainly, I think that the main purpose is to be more precise. So we will gain in precision of diagnosis, having several nights instead of only one night. But definitely, it's a way of opening a new avenue, and we don't really know where we will end up at the end of the story. But of course, progress means trying new things.
Yeah.
I would like to echo some of Marisa's aspects. The critical point is that we do not simplify our field and lose quality. So we do not save time on the physician side or on the technician side. not so much. We save time on the patient side, coming to the hospital or to the sleep lab or staying at home. So if we make sleep medicine on a good quality, then it takes the same time for us.
Okay.
Of course, we might need, we might get some automatic help to pre-select or evaluate studies in the future better than today. That would be helpful. But I'm a little bit afraid that we only focus on classical obstructive sleep apnea. So by our field, not only in respiratory sleep medicine, but in sleep medicine as a whole, we must not oversee insomnia patients with movement disorders, in addition to minor breathing disturbances. And that, I think that's the biggest risk. Of course, companies are very interested in finding many patients, to put many patients on devices, but that cannot be our approach. On the other hand, there are so many untreated patients who need help, so we have to go this way. Maybe it's helpful to find a good pre-selection approach, and that I think we have to work on that to find better pre-test probability, putting patients in RAWs, clear sleep apnea or very probable sleep apnea, not probable sleep apnea, probable insomnia, and so on, and then find out individual diagnostical approaches.
Yeah, I completely agree. And in that respect, I think it's appropriate to say that we are also looking at that aspect in Sleep Revolution, where we're now developing new patient-reported outcome measures, new questionnaires that really can help in pre-selecting which way to go, respiratory, neurological, etc. So I think we have almost come to a close now. I think we had a very interesting webinar. And before going to the concluding remarks, I would like to remind the audience that the Sleep and Breathing Conference is approaching quickly. So the number of registrations is rising, and this will be an excellent opportunity, not only to meet the speakers of today in person, but also to update your knowledge and skills in the field of sleep and sleep medicine. Having said that, I would like to thank all the speakers for their excellent contributions, for their new innovative work that they have presented. And I would like the people at home, the audience, for being with us and for staying with us until the end. Thank you very much. Bye.
Thank you, Dirk.